Good morning to some and good afternoon to others. Welcome everyone to today's webinar hosted by the Region 8 chapters of HFMA. Today's webinar is titled An Overview of Comprehensive Primary Care Plus or CPC Plus and Strategic Considerations. Before we get started, I would like to review a few housekeeping notes. All phone lines are on mute to avoid interruptions during the broadcast. In your audio panel, you may select to listen to this broadcast using your computer's mic and speakers, or you may select telephone to receive a dial-in number. To access a copy of the presenter slides, please expand the handouts panel located to the right of your screen and select the PDF icon. During the presentation, we will present the audience with 3 polling questions. Be sure to submit your response when prompted. All individual responses will not be shared with the general public, but this is a great way to see how you're positioned among your peers. At the conclusion of today's presentation, we will have a Q&A session. However, you may submit your questions at any time by typing them into the questions panel also located to the right of your screen. I'd like to welcome today's guest presenter, Steve Smith. Steve is a member of the Physician Services Center of Excellence and Payment Reform teams. He's with BKD Advisories. He provides consulting services to provider groups and healthcare organizations related to payment reform initiatives, revenue cycle, process improvement, and compliance. Steve has provided detailed presentations on the Medicare Access and CHIP Reauthorization Act of 2015, Comprehensive Care for Joint Replacement, Comprehensive Primary Care Plus, and numerous other payment reform initiatives. Mr. Smith is an HFMA member and a fellow of the American College of Healthcare Executives. So without further delay, I'll hand the call over to today's guest presenter. Steve, please go ahead.
Good morning, everyone, and thanks for joining us today. I do apologize for kind of the short turnaround for the announcement of the webinar and trying to get this out. Unfortunately, under the program, and we'll go over this in detail for a timeline later on in the presentation, but applications to participate in CPC Plus do have to be submitted to CMS by July 13th. So there is only a month between now and the time when these applications have to be received for consideration by CMS. So we definitely wanted to get this out to everybody as soon as we could. That way you guys have an opportunity to go back, talk with your administrative team, talk with your clinical team, see if this is something that's going to fit what you want for your practice, fit the future plans for your practice, and kind of start your planning accordingly. So again, thank you very much for joining us this morning. A quick agenda for what we're going to be looking at. We're going to spend the majority of our time on an overview of the model, and that's going to be looking at both care delivery and payment innovations. And so there are certainly things that are going to have to be done differently as a CPC Plus practice compared to what some may be doing today. And there's certainly some health IT requirements that you're going to have to make sure that your practice can achieve, your IT system can achieve, and depending on the track that you submit, may have some pretty detailed incorporation of your IT vendor, both in terms of system readiness and system support, to be able to participate. So we certainly want to make sure that we highlight those items for you, and then we'll certainly dive into the timeline, at least the timeline that we have as of now for this program, and then we'll certainly open it up for some Q&A towards the end. If we don't have time to get to everyone's questions today, absolutely feel free to either email them out to me. I'm sure we'll have some follow-up questions that I can answer as well. So definitely want to make sure that we can answer those to the best of our ability. So Nick, if we can go ahead and start with our first poll question here. I just want to kind of gauge everybody's familiarity right now with the CPC model.
Perfect, and that is on the screen right now. So if you could just make your selection, let us know how familiar you are with the CPC model, and then we will continue with the presentation. And guys, you are really fast. I didn't even have a chance to cue up any music. So let me close this out, and looks like we are right at 88%. Last call. All right, close that out. And let's look here. So not sure if you can see this, Steve, but at least 43% have heard of CPC. We had another 35% who are somewhat familiar. 13% says this is the first time they've heard about the model, and then another 9% say they are very familiar.
Good, and that's very typical of kind of the distribution that we see when something like this comes up. CPC is slightly different in that this is now the second round, so Nebraska is included in round 2 of this. Round 1 began 1/1 of 17, so there's a little bit of history there, but a lot of times with something like this, if it doesn't directly impact you, you're not going to spend a lot of time trying to learn about it. Now that we know that Nebraska is in, and we know it's available, we certainly see people start to become more and more familiar. So, definitely along the similar distribution lines of what we normally see. So for CPC Plus, CMS has really identified a few primary objectives for the program. And first and foremost is advancing care delivery and payment practices. And so what does this mean? Well, we'll go into a lot more detail later on in the slides as we start diving into these specifically, but keep in mind, as you're trying to identify if your practice wants to take part in this or how you can demonstrate your practice's ability to advance care delivery and advance payment practices, hopefully you have a little bit of this in thought already. And so when it comes time to communicate to CMS what you plan to do or what you're capable of doing, you've already had some of these conversations. That'll be very crucial to kind of attesting to CMS that, hey, we're prepared and we're really committed to doing this. Accommodating practices in different levels of readiness. As I mentioned, there's a couple different tracks. Track 1 is kind of the introductory, okay, let's really kind of expand the scope of services that we provide. Track 2 is much more complex. So it's, we've already kind of gone down this road. Now how can we greater utilize IT? Or how can we greater expand the activities that we've already performed and kind of get into this track? And track 2 will also take into consideration some payment reform where everything will not just be fee-for-service payment anymore through CMS. And we'll, again, go into the greater details on that later on in the presentation. And then, achieving these delivery systems. So, how are we going to achieve better care, smarter spending, and overall healthier people? Well, if you relate all those back to the first objective here, advancing care delivery, you're really going to take care of your better care and your healthier people. You're going to have more access. You're going to have more services. All that stuff will be there. So, those are really the ways that CMS is going to make sure that all these objectives are kind of met. It is going to be a 5-year program beginning in 2018. Now, this is specific timing for the round 2 practices. Round 1 practices began in 2017, and they are also going to be a 5-year program. This is kind of an interesting bullet point. So CMS does expect that when a practice dedicates itself to enrolling in this program, the expectation is you're going to be participating for the full 5 years. That being said, you are allowed to withdraw without penalty. So, you don't have to worry about paying back any funds or anything like that. What I would say is, and although this is quite frankly not publicized anywhere, but if you as a practice were to commit to CPC Plus, determine later on, this really isn't for us, this isn't meeting what we wanted to, this isn't really helping us the way that we had hoped, and you do decide to resign from that program, I think it's a reasonable expectation to assume that CMS will probably make note of that. And so if you were to apply for other future payment reform systems, and we all know those are going to be on their way, we don't know exactly what they are, but reform certainly isn't going to stop. CMS may want to make sure that you haven't withdrawn from any programs in the past. So while you do have that withdrawal without penalty clause in there, do understand that you are expected to participate for the full 5 years. Also note that you are not allowed to join the model after the round begins, at least the way it exists today. So, could that change later on down the line and they decide, you know what, we didn't really get as many practices as we would like, so let's maybe reopen it again. I suppose that could happen, but keep in mind those that were in round one beginning on 1/1 of 17 were not allowed to reapply or apply for a first time during this round two period. Those round ones have been completely closed off. So, for example, Kansas City practice was included in round one. If you did not participate and you did not submit to CMS or sign up with CMS, now that round two is here, you do not have that entry capability. So keep in mind that as of now, this is your one shot to get into the model. We did have 14 rounds that were, or regions, I should say, that were chosen in round one. And now we do have 4 additional that are in round two. And one of the biggest caveats there was there had to be payer interest and significant coverage. And so third-party payers. So, for example, in Nebraska, we know that Blue Cross and Blue Shield is in this program kind of in partnership with CMS. Now, that is a loosely defined partnership. Effectively, Blue Cross and Blue Shield, in this example, has to convey to CMS that they are committed to the same kind of tenets. Yes, we want to see payment reform. We want to see something other than just fee-for-service medicine being reimbursed, and we want to expand the care that's provided to our covered lives. That doesn't mean that they have to follow to the T the payment practices that have been set out by CMS. They do have the capability to kind of customize it to what will work best for them. And so if you do have questions between now and the application period, I'd certainly recommend reaching out to Blue Cross and just asking them, hey, we know that you guys have partnered with CMS for round two of CPC Plus. What do you think your payment is going to look like? And they may not have it finalized yet, but hopefully they can at least speak to the general outline that they're at least considering, so that you can take that into consideration when you make your determination of, yes, I want to apply for this, or, you know what, maybe this really isn't available to me. And then lastly, we do have those 2 tracks available, as we had discussed previously, both the kind of the introductory and then the much more expanded track 2. So what does this mean? We've talked about care delivery. That can mean a great number of things, but CPC Plus really breaks it down into 5 different categories: care management, patient and caregiver engagement, planned care and pop health, comprehensiveness and coordination, and then access and continuity. And so each one will have requirements that have to be met based on the different track that you may be in. Again, track 1 is going to be fairly introductory, where we're expanding the scope of care, we're providing additional access, we're expanding the scope of services that may be provided. And then again, in track 2, you're taking that to really kind of the next level. And so where you may have some planning meetings that just need to take place in track 1, those need to take place more frequently in track 2. It may need to cover additional information in track 2. And again, we'll go into an overview of these tracks. Based on the time that we have today, we really don't have the time to sit down and go through the specific details of the 2 tracks. What I would recommend towards the end of the presentation, there are some links, and some of those will be off the CMS website and FAQ documents. Those do provide a good background of specific requirements for each of these action items in both tracks. I would highly recommend folks go out and review those documents as a part of the internal decision-making process and planning process that everyone will go through. So let's start here with, what do I have to have for track 1 and track 2? Well, for track 1, you have to have at least 150 attributed Medicare beneficiaries, and that designation is made by CMS. So already, if you're a very small primary care office and you only have 75 attributed Medicare beneficiaries, let's say either you have a high commercial base and you don't see a lot of Medicare patients, or you're just a smaller practice, you would actually not qualify for track 1 if you don't have at least that 150 attributed Medicare beneficiaries. And if you have questions about that, you can certainly contact CMS and just say, hey, I've got to get a ballpark for how many attributed beneficiaries I have. Can you give me that? And hopefully they can put you into touch with somebody who can take care of that for you. You have to have support from the CPC Plus payer partners. The good news is with Blue Cross Blue Shield already partnering, with CMS, they're really already committed. So you really already have that. This third one is big, and you have to use certified EHR technology, and that can be a roadblock for some practices. Those systems are not cheap, and we're all certainly aware of that. But it does have to be a certified EHR system that is in use within the practice. So certainly something that needs to be taken into consideration. And then you have to be willing to take on these existing care delivery activities. So this is not a complete list, but these are kind of the overall tenets. So you have to assign patients to provider panels. And that's going to be a big part of the decision-making process and the care delivery for these patients going forward. The 24/7 access to patients. This does not mean that somebody needs to be sitting in the office 24 hours a day, 7 days a week. But they do have to have access. Now that can be phone access, that can be e-visits, but it can't be, hey, it's 5 o'clock, we're closed, or it's 6 o'clock, we're closed, call us back at 8 o'clock or 9 o'clock or 9:30 the following morning whenever your practice may open. They have to have that 24/7 access. And then supporting quality improvement activities. And this is, any kind of payment reform that CMS has come out with, whether it be MACRA, whether it be CPC Plus, whether it be CJR, any of the advanced payment models that have come out. Quality improvement has been at the forefront, and that is certainly not going to go away. That's going to be a tenet for CMS going forward, and something that we'll continually see there. But again, that support and that desire to improve quality has to be there and has to be able to be communicated to CMS. So let's say, okay, you know what, we're already doing this stuff. We feel like we're really well positioned. We've really bought into this way of practicing. And so we'd like to take it a step further. And if you do that, then you can qualify for Track 2. Again, it is going to be more complex. You're going to get into developing and recording care plans for all of your patients. Doing timely follow-up with all of your patients after an ED or a hospital discharge. Looking at implementing a process to link them to community resources. So, I have a patient who, is maybe pre-diabetic or diabetic. What community resources exist that can help this patient, that can get them education beyond what I can provide in the office setting. And then this can be a big one here as well, applying with the letter of support from the health IT vendor. And this is going to do a couple different things. Not only is this going to obviously certify that you're using the EHR technology, because you'll have your IT vendor. But a couple big things is, number one, the vendor has to identify that, our system is capable of doing all these things, but more importantly, we are committed to supporting the practice in optimizing their health IT. So it's not just that, yes, my Allscripts or Cerner or Meditech or whatever system you may have, our system does this. Okay, that's all fine and well, but are you going to support the practice beyond just providing a software package? And what is that support going to look like? And if you go out to the CMS website, again, those links are later on in the presentation. There is a sample vendor support letter that's out there that CMS has published, so you can certainly use that and submit that along with your application if you're desiring to get into Track 2. So let's start diving into these categories that we discussed earlier, the first of which being access and continuity. So for Track 1, you have to be able to empanel your patients. You have to be able to assign care teams to your patients. So it may be that they have dedicated nurses or dedicated physicians or dedicated groups, depending on the diagnosis or the ailment or the patient's history. Some sort of empanelment and care team, assignment has to be there. And then, again, that 24/7 patient access. And again, this does not have to be physical access, but they have to be able to, call into an answering service and get a call back, within a reasonable amount of time with questions they have about their ailment or anything that comes up. So that's for Track 1. That's kind of your baseline. Track 2, then, you really have to start to provide alternatives to traditional office visits. So it may not be enough to say, okay, great, we'll see you here between 8 and 5. Now we've got to start looking at e-visits, phone visits, home visits if it's, possible. Expanding your hours can be one way this can be accomplished. So yeah, traditionally we had done 8 to 5. You know what? We're going to start going 7 to 6 or 7 to 7. And certainly that needs to be run through the clinical team. It needs to be run through the administrative team. There's going to be costs that are associated with it. It may be that additional staff are needed. All those things kind of go into that decision-making process, but certainly needs to be discussed and see if this is something that can be done and if the practice thinks is beneficial to do. Care management, then, we really start looking at risk stratifying our patient population. And any time within CPC Plus that we talk about risk stratification, we're going to be looking at those HCC, those hierarchical condition coding. And so how, do we have a lot of high-risk patients? And if so, we need to make sure that we're caring for them accordingly. Relationship-based care management. So, hey, we saw you today. We want to see you back in 30 days, and we want to see X, Y, Z results, all that stuff being shared with the patient. So it's not just, great, you're here, we're going to treat you, and then if you have any questions, let us know. It is much more of a engaged, short-term, targeted relationship they really want to, start to have here. And again, with the ED and hospital visit follow-ups, you have to have that in place. And a lot of that is going to be reliant upon the hospital's ability to get you that information. And so, do you get fax copies of H&Ps or discharge summaries for EDs or hospitals right now? And if not, what's it going to take to get that done? Track 2, then, you're looking at 2-step risk stratification. So it's not just that we're going to risk stratify based on what was done today. Maybe we need to look at what was done today as well as what's been done in the past for the patient. Does this indicate that the risk is increasing for the patient, or are we managing it pretty well and we're starting to decrease that risk? But if you do have someone that is in a high-risk chronic disease state, whether that be COPD, CHF, things like that, what care plans are you going to put in place, and what resources are going to be required to put those in place? Are we going to have additional visits that are required? Are we going to have additional testing that's required? All that stuff will need to be taken into consideration for the care management plans. Comprehensiveness and coordination, and this can be really kind of a difficult one, specifically once we get into track 2, but we'll stick with track 1 for now. The identification of high volume and high cost specialists. A lot of places don't have that capability, and so how are you going to go about that? Are there vendors that you can engage that do data analytics that can give you an idea of what specialists are in your area, or what their average cost per beneficiary is, or how can you get to that information? The timeliness of information on transfers from EDs and hospitals or discharges from EDs and hospitals, all that information, how can we get it quicker? Yeah, great. If we're getting it 5 days later, well, that's good. I at least know that they were there and they've been discharged. But now if they've been sitting at home, how are they doing with their medication? Do they have any questions about their medication? Can we decrease that time frame from 5 days to 3, or from 3 days to 2, or whatever that decrease may be? Getting into track 2, then, I think one of the biggest issues that we've seen, at least in the Kansas City market for the round 1 practice, has been this behavioral health integration. And part of it is because of the behavioral health market here in Kansas City is sparse. We are certainly at a need for the behavioral health professionals, and my guess would be the Nebraska market is very similar. And so it doesn't necessarily mean that you have a behavioral health professional on staff and in the building at all times while you're open. It could be that there are standard hours and there's almost a rounding procedure that takes place, but that does need to be integrated somehow. And those needs and assessments of the patients need to be done. And so again, it's just a matter of determining, well, how can we accomplish this? What resources do we have now, or that can we work with later, to be able to accomplish these goals? And so again, certainly something that needs to be taken into consideration. And again, as we get into these high-risk populations, what can our practice do? What capabilities do we have? What specialists do we work with? What educational materials do we have that can help meet the needs of these high-risk populations? Again, do we expand our office hours so that we can greater accommodate visits and open up some slots, or What exactly are we going to do? These are all things that you're going to want to be able to communicate to CMS when you apply for the program. Patient and caregiver engagement. Quite honestly, this is an area that's not always the biggest challenge because most of the providers want to do this anyway. The question is, how do we carve out enough time for them to do it? So as you look at track 1, annual patient and family advisory council meetings, that can happen. The question is, again, how do we carve out the time to make it happen? And then assessment of practice capabilities to support patient self-management. Again, do we have a portal? And does that portal provide educational materials to the patients? If it doesn't, what would it take to set that up? And in a track 2, you start getting into biannual family advisory council meetings with the patients. Supporting at least 3 high-risk conditions. Some of these things, when you look at the kind of self-management aspects of both track 1 and track 2, may only require a lot of time once they're initially set up. And after that, the information's there. We just need to make sure the patients are aware of it. It's really the patient and family advisory council meetings that become difficult from a time standpoint, especially if you're trying to cut out, biannual meetings. What do those look like? How are they going to be scheduled? How do those need to take place? All those things need to be taken in consideration. But again, a lot of providers are very proactive in doing these things because it does improve patient care, and that's why a lot of them do what they do anyway. They want to provide the best care possible for their patients, and this is a great way to get that done. Planned care and population health, at least quarterly reviews of payer utilization reports for track 1. For track 2, you're looking at least weekly care team review of pop health data. So again, what does your system look like? What access to data do you have? And what is it going to take to be able to carve out time for your team to meet either weekly or quarterly, depending on what track you want to get into, to do this? How is all that going to look? How do we carve out this time? And we'll talk a little bit later about how CMS is, providing some funding to be able to do those things. But again, and I'm beating a dead horse here, but certainly things that need to be taken in consideration prior to enrolling into this program, because you do want to make sure it's a fit so that once you do enroll, you are in for that full 5-year period. I know that was kind of a quick and dirty overview, but I do want to get a general feel for everybody. How well do you think you are prepared to meet these metrics, whether it be track 1 or track 2? How well do you think you're prepared today for everything you're going to have to do?
Perfect. So that poll is on the screen now. So if you could just take a moment and let us know, based on the information that you've heard here today or elsewhere, how well prepared you feel that your practice is. And we have another poll right after this one that is specific to the 2 tracks that Steve has spoken about. Fast again. So we have about 93% of the votes in. Let's close this out, and let's just see what everybody said here. So we had 37%, the highest number that feel that they're somewhat prepared, followed by 26% who just aren't quite sure yet, or this may not be applicable to their organization. Followed by 19% who are well prepared, 15% who are not prepared, and 4% who are very well prepared. All right.
Very good. And the one thing, before we go on to the next poll question, Nikki, the one thing I would recommend there is for anyone who's in that kind of boat of, we think we're somewhat prepared, or we're not sure, or we're really not prepared at this time, definitely go out to that CMS website for the innovation site for CPC Plus. Review some of those documents, review some of those specific requirements for the areas that we've kind of provided an overview here. That'll hopefully clarify some of that. And certainly you'll want to reach out to your IT vendor to see what their capabilities are and how well they're positioned for this. But definitely go out there here fairly soon, just because of the time frame, to really get a feel for, boy, you know what, maybe this isn't for us just based on where we're at today, so that you don't run into that issue of, boy, you know what, we really wanted to do this, we applied for it, and maybe it turns out this wasn't the best thing for us. It really needs to make sure, every practice needs to make sure that this program is not seen as a revenue driver. It's seen as a way to transform the practice. And a lot of that has to do with what your baseline is today.
Great guidance. Thank you for that. I'm sure the audience thanks you for that. And as promised, this is our second poll. So you saw the two characteristics of the two tracks that Steve spoke about. So which do you think would be ideal for your practice, or which would you be well positioned for? One or two, if you're still not quite sure, or you think that you aren't well positioned for either of those tracks, if you can make that fourth selection. And then we will let Mr. Smith continue with his presentation. Yep. All right. Speak now, forever hold your peace. We have about 80% in, so we'll go ahead and close that out. And let's see where everyone falls. So the majority feels that the track one is the one that their practice is best positioned for. 14% said track two, at 32% who are not quite sure. But no one said that they aren't positioned for either track, so very interesting.
Very good. And again, very similar to what we see in other presentations that we do on this topic. You know, track one is just, I don't think forgiving is the right word, but I'll go ahead and use it. It is more of that baseline, hey, we know we want to transform our practice. This may be the opportunity to let us do that, so that's really the track we want to pursue. So, you know, definitely, again, not out of line from what we've seen in other presentations. So let's get into the real fun stuff, and something I'm sure a lot of people have questions about. This is a lot of stuff that's going to cost me money, so how is this program going to affect payment? And what's going to happen? And well, there's a few different ways that practices are going to be reimbursed under CPC Plus. And the first of which is care management fees. And so these are risk adjusted. Again, this is based on the HCC scoring. So one thing that I would highly urge practices to do is review your current HCCs, your hierarchical condition coding. See where you stand today. How much of it is seen as high risk? How much of it is seen as kind of a low risk? They fall in that first quartile or that second quartile. Because that will impact the funds that you receive based on which track that you're in. And the key thing to point out here is payments are going to be utilized to augment staffing and training in support of POP management. So what you're really doing here is subsidizing, if you will, your ability to bring on additional staff, to train staff in ways that maybe they hadn't been trained before, and look in that information. And again, it is going to be Medicare that assigns, or that coordinates, I should say, the HCC score along with the attributed beneficiaries. And so it's Medicare that's going to say, okay, practice X, we show that you have 175 beneficiaries. Here's how they split up based on your HCC coding, and therefore, here's the care management fee that you're going to get each month from us. You'll see in track one, that can range from $6 to $30. As complex, whether they're in the top 10% of HCCs or if the patient has dementia, are not separately reimbursed in track one. In track two, however, that ranges from $9 all the way up to $100 if you get into that complex tier. And so as you look at your average per beneficiary per month, that's at PBPM figure towards the bottom of the screen. Track one, you're looking at about $15 per month. Per beneficiary per month, I should say, and track two, you're looking at $28. So again, you know, we know that track two is expanded; it's going to cost more, and so CMS is providing some additional reimbursement there. But again, highly recommend folks review their HCCs, see where you're at, see what your historical performance has been, and quite frankly, does that seem right? Or do you think possibly we need to do some coding training, or are there aspects of our coding that I think might be missing? Do we need to do an audit of our coding? If you do feel that, you know what, our HCCs really should be higher based on the acuity of patients that we see, definitely an internal review that should certainly take place when it comes to planning for this. You know, we also have, you know, a couple options. This will not apply to track one. Keep in mind that track one will continue to receive Medicare fee-for-service payments, and so there will be no, you know, effectively claim payment reform, if you will, for track one. For track two, however, you get to select a kind of hybrid model where you're going to have some of your reimbursement based on fee for service, so the claim you submitted based on the fee schedule, here's what you get. You'll also have a comprehensive primary care payment, and this is where the CMS will identify what you've historically done, what your historical cost has been and your claim payment has been, and you'll actually receive these payments up front. The kicker then is your fee-for-service payment will be reduced by whatever percentage you elect, and you'll receive that after claims are submitted. So again, this is an additional fee that you'll be getting up front that you can apply towards augmenting staff or bringing on additional staff, expanded hours, training, whatever you think you need to do to position yourself. This gives you that capability. You'll note that beginning in 2018, you have a wide variety of options. In 2019, that decreases slightly, and then beginning in 2020, you really have a couple options that you can pick from. You're either going to do 40-60 CP-CP to fee-for-service split, or 65-35. And it really just depends on how much risk your practice is willing to take on. There will be a reconciliation afterwards. So, hey, we paid your CP-CP at either 40 or 65%, whatever you choose. However, your quality improvement and your quality scores really weren't as high as what they should have been, so we're going to have to recoup some of those funds. Keep in mind that can certainly happen. Obviously, we hope it doesn't, but it certainly could. But you'll note that you do have those options. Now, I should note that you do have the ability to change your election in any given year. So let's say hypothetically in 2020, you decide, what, we want to do a 65-35 split. We're really going to be aggressive, and we want to take on some of that risk and have some of those funds up front. For one reason or another, you determine that's not really our best course of action, you can slide back to that 40-60 split in 2021. You just have to make that election to CMS, but you do have that capability. And then the performance-based standard. Again, this is a per beneficiary per month payment that'll be kept by the practice as long as your annual performance thresholds are met. And so again, this is going to tie back to your beneficiary assignment by CMS. But if you're in track 1, you have a total per beneficiary per month payment of $2.50. Again, that'll be a monthly fee that you'll get up front, as long as your utilization and your quality are met. If those are not met, you will have to potentially pay back some of those funds. But as long as those are met, that's yours to use towards practice transformation. Track 2, then, you have $2 for utilization, $2 for quality, for that total of $4. And so again, funds that can be used proactively as a way to increase the funding you have available for some of those expanded hours or training or whatever you determine you want to be able to use that for. And so looking at a basic summary of those items, in track 1, you have your per beneficiary per month care management fee at an average of $15 per beneficiary. You have your performance-based incentive payment, and then you also have your payment under the physician fee schedule, where you're just going to have your fee-for-service medicine payment. Track 2, then, you have an average of $28 for your care management fee. You do have one extra $100 if you have those complex patients. So if you have a large dementia population, maybe this helps you better care for them. And so maybe track 2 becomes an attractive option. Just like with track 1, you have your utilization, quality, and your experience components for your performance-based incentive payment. And then you also have the decreased fee-for-service, but an increased monthly fee that you'll get up front. And so again, when picking your tracks, you really have to determine not only what is my practice capable of from a clinical standpoint, but what do I feel comfortable with, and what am I capable of, and how can I use some proactive monthly fees to kind of transition the way that I practice care in this environment. And maybe track 2 provides that opportunity, understanding that you're going to have to do more, and it's potentially more costly, but you do have that additional revenue that's coming through as well. While we're talking about payment, we do need to identify what can I and what can I not use some of these funds for. It's very important to note that when applying to this program, you have to inform CMS how you plan to use these funds, and then you also have to have the capability of identifying how we did use these funds. So it's not only this is why we're doing this and this is what we're going to use these funds for, but at the end of the year, okay, CMS, these are the funds that you sent to us, and this is what they were used for. And so you have to be able to provide an accounting for that. So when thinking about this program, I think it's beneficial to think of it almost as a grant program, where we have to be able to identify the money that we've received, and we have to be able to identify how that money was spent. And we have to be able to provide that to CMS on an annual basis. You know, it's certainly not going to be acceptable to bring in care management fees and then not really expand your scope of care. CMS will certainly frown upon that and will want to recoup some of those funds. So you have to be able to identify them and also identify how they were spent. And so permitted, you know, wages for new existing staff. We know we're doing this additional stuff. How are we going to do it? Do we have to increase the wages? Do we have to increase the hours? What's going to be required? What care delivery tools are we going to use? Are there decision-making tools that we can use? Are there coding tools that we can use? What care delivery tools are we going to implement? And what training do we have to do? And that can include travel. That can include bringing in consultants. That can include bringing in CMS to do some presentations. Meeting with you know, other individuals in the regions. You know, contracting with behavioral care professionals. All that can be a permitted expense. What is not permitted is HIT purchases and upgrades. So, you know, you cannot use the funds to now say, okay, now we can go out and get a certified EHR system. It's just not permitted. The income tax payments, and you can see the list. I don't want to waste time by going through line by line, but the application that you'll receive, if you're chosen by CMS, the application that you'll receive, the formal application, will identify what are permitted and prohibited expenses. And so you'll want to review that very carefully if you are chosen to participate in this program. And then, Nikki, we have one final poll question here related to the payments under the system.
Now this one, actually, it looks like we have a little issue here where it won't pop up. So I tell you what, why don't you go to that Q&A? We're going to circle back to this poll question. Does that sound okay? Perfect.
Absolutely. So looking at the health IT requirements then, we had touched on them briefly before, but you do have to have something that meets the definition of certified EHR technology, and you are going to have to be on that 2015 edition. Again, this is going to be by January 1st of 2018. And so you're going to have to be able to work with your vendors to identify if they're going to be able to get to that standard or not. And then the quality reporting requirements, I would certainly reach out to them, to your vendors, to make sure that they can meet these requirements. They're going to know exactly what these are. They're going to know what C1 through C3 are for ECQMs. They're going to know all this stuff, and they're going to hopefully be able to filter that data by the practice site location and the 10 NPI. So certainly reach out to them for questions on that. And then track 2, you do have to have these additional requirements. I had mentioned there is enhanced functionality they have to have. You've got the link there where you can go out and view that information. But also make sure that they hit the second bullet point here for the adopted Health IT 2015 edition for social, psychological, and behavioral, because that can be, while it doesn't have to be there in 2018, it has to be there in 2019. So they'll have to make sure that that's on their radar and something they have planned to be able to comply with. So timeline, you know, February 17th, we had the second round of payer solicitations, which began. As I mentioned, Blue Cross Blue Shield is in for Nebraska in addition to CMS. So on May 17th, the regions were announced, and that's where we found out that Nebraska was in. And then beginning on July 13th, or I'm sorry, by July 13th, you have to have your applications into CMS. And I think a really good way to think about this is almost like a college application, where you're going to CMS and you're saying, hey, you know what, I would be really great for your program, and here's why. Here's why you should invite me into this program to take part and to really help strengthen your desire to enhance care and change the way that payment and care is delivered. And so you really want to kind of state your case. because what's ultimately going to happen is CMS will then select practices and say, okay, practice X, you're in. Practice Y, for one reason or another, we've decided this program probably isn't right for you, so thank you for your interest, but we've decided to pursue other opportunities. If you are selected, then you have to complete the submission, or complete and submit the participation agreement. And as I mentioned, that's where it's going to get into the details of this is what's required. These are the expenses that you can or cannot apply for your upfront fees that we're going to give you. It really starts diving into those levels of detail, and so you should have ample time. You know, when they did this first round of practices, you know, I think they had them selected by about September or October, which allowed practices then to really kind of devote time to review that agreement, make sure this is something that they want to do after reviewing that agreement, and then ultimately signing and submitting that to CMS to say, okay, yes, CMS, we're going to partner with you on this. So again, you really are looking at this like that college application. You know, I'm going to apply. They may select me, but you know, I still have that right to say, you know what, I've continued to think about it. Maybe this just isn't for me. You know, maybe I just don't want to participate in this at this point. That is certainly acceptable to do. Right now, you know, the urge that I would have is if you think you have even an inkling of wanting to participate in this model, submit that application, get that over to CMS, get on their radar. They can review your practice, review your history, review what you've submitted to them, and say, okay, yeah, you know what, we do think you'd be good for this. And then you have the ability to say, you know, we do appreciate it, you know, but after reviewing the agreement, we just don't think this is right for us. So understand that by just applying now, there's no guarantee that you'll be in. There's also no requirement that you stay in. So this is really kind of that time where, you know, we think we have just even a little bit of an interest. We at least want to get on CMS's radar. As I mentioned, we had the links here. I do apologize for the typo there for macro links. That is CPC plus links. But since we're talking about macro, I do want to point out that CPC plus is identified as an advanced APM. So for those of you that are familiar with macro, if you are in an APM, one of these advanced APMs, you do not have to submit MIPS data. And so this can be a way to get out of the MIPS track under macro. You do get a 5% lump sum bonus of your Part B allowed charges. And so this could be an alternative for a lot of practices who decide, you know what, maybe just the CPC plus incentives aren't enough for us, but if we combine that with the macro opportunity that this presents, boy, maybe this is a real opportunity. And maybe this is a way that we can have some additional financial incentives that we can pursue. So it definitely kind of sweetens the pot, if you will, and makes it even more of an attractable track than I think maybe it was when round one was released. You know, CPC Plus really wasn't in as a formal advanced APM, and so that additional 5% of the physician Part B allowed charges wasn't there as an incentive for those practices. For round two, it is. So again, something that needs to be taken into very careful consideration. And really kind of evaluated both from a financial and a practice management standpoint to see, boy, you know, does this kind of make that more of an attractive opportunity for us? And at that point, Nikki, have we been able to solve that poll question?
Yes, indeed. So right there on your screen, everyone should see this final poll question, and it's perfect timing. Do you feel your practice is currently equipped to be able to separately identify and track revenue and expenses for prospective CPC Plus payments? So the answers are simply yes, no, or if you're unsure. So while you're making that submission, also just a heads up, so as we approach the Q&A session, feel free to just type in your questions into that questions panel, and we'll address as many as time allows. As Steve mentioned, he's gracious enough to provide his contact information for any questions that we don't get a chance to cover, and I'm already seeing some great ones come through. All right, so let's close this one out. Let's just take a quick peek at how everyone feels. It looks like 39% said yes, 43% are still not quite sure, and then 17% said no.
Very good.
Right.
So for those of you that are unsure, I would certainly loop in your accounting department. I think that probably goes without saying. And it may be that they can even develop a separate GL, for these accounts, so that we can identify, hopefully, those payments that do come in from CMS on a proactive basis. Do we have the ability to just set that up as a separate GL and be able to track that information as well as some of the spending? Where spending can, I think, get difficult to identify is how much of this was done today versus how much of this, is being done because we've entered into this program. And where I really think about that is staffing. And one way you can look at it is the number of hours that were worked. You can look at it from a standpoint of, did we increase hours that were open? Did we increase hours that staff has to be there? An easy way to do it is, hey, we've identified that we brought in Nurse Smith because we had to have somebody that could help us with CPC Plus. And so Nurse Smith's expenses are going to be very easy to identify. Where it could be difficult is, well, Nurse Jones has always been here. We're just expanding her hours. And so how do you identify what that's going to be? And so, it certainly can be done. It's just a matter of how difficult will it be, how capable is your accounting software or your accounting system of tracking that information, and then also from a revenue standpoint, how capable is your billing and or finance department to identify those payments that are coming in. Obviously they're not going to come on an EOB or anything like that. So what do we need to have in place to be able to identify, hey, this is a CPC Plus monthly payment, we know that, so let's make sure we track that over in XGL or as a sub-account or however you need to set that up. But, definitely loop those folks into the discussions as well.
Perfect, thank you. So let's jump into those questions. The first one I have is, what is the role of non-Medicare payers and CPC Plus?
Sure. So, as we pointed out in the beginning of the presentation, one of the big things for CMS was it can't be just us that's doing this. In order for a region to be selected, they had to have commercial payer support as well. And again, for Nebraska specifically, we know that Blue Cross Blue Shield was that payer. And so they have to adopt similar, not identical, but similar program requirements. And so, we're likely looking at upfront payments to be able to help practices transform. We're looking at some payment reform in terms of, we'll maybe decrease your fee for service, but we'll give you an upfront payment as well. And so all those things have to be there. And so again, if you're considering applying and have questions about how that's going to look, I would highly recommend reaching out to Blue Cross Blue Shield there in Nebraska. Get a feel for what their plan is. Get a feel for, are they just going to follow the CMS model, or are they going to try to do a slight hybrid of that, and what might it look like? Again, they may not have that finalized yet, but hopefully they can at least speak to what their initial plans are and what they envision that being.
Great, thank you for that. And the next one, how will Medicare beneficiaries be attributed to CPC Plus practices?
That's a great question. And so CMS is really going to look at how many of the beneficiaries that are out there, where have they been in the most recent 24-month period? And so if they identify that patient Smith had seen provider X, let's say 6 times in a 24-month period, but they saw provider Y 1 time in that 24-month period, well, that patient is going to get attributed over to practice X because, it looks like that one outlier visit may have just been a scheduling issue, something like that. So, if they have that, and if there is that large discrepancy, it's fairly easy to see where that patient should be attributed. Where it gets tricky is if a beneficiary has an equal number of claims for primary care services at more than one practice. And so 3 times at practice X, 3 times at practice Y. What CMS is going to do is take a look at who had the most recent data service. And if it was practice X, that patient is going to be attributed to practice X. If it's practice Y, that patient is going to get attributed over to practice Y. And so, it is kind of a two-tiered approach that they're going to be taking, but they're going to look at historical attribution and effectively see what practice was utilized and how recently.
All right, thank you for that. And our next question is, we are an RHC clinic, which I believe is a rural health, hope I'm not misspeaking there, and do not qualify for CPC Plus through Medicare guidelines. Would we still be eligible for CPC Plus through Blue Cross Blue Shield?
No. If you do not qualify for the CMS guidelines, you cannot qualify with Blue Cross Blue Shield. Now, one thing that you might want to ask Blue Cross about is, hey, I know I don't qualify under CPC Plus through Medicare, but I know that you're interested in doing this. Can we come up with a services agreement and a provider agreement that isn't just the traditional fee-for-service Medicare, or reimbursement, I should say? They might be open to that conversation, and so it might be willing to walk down that road and say, hey, Blue Cross, I know you're looking at transforming the way things are happening. We're interested in doing so, but because of our designation, we aren't able to apply with CMS and partner with you in that way. Can we change our provider agreement and possibly just put in some of these tenants that way? I can't guarantee that they would be open to it, but it certainly might be something worth inquiring about.
All right, very great guidance. And the next question is, what resources will CMS provide to help practices succeed under the CPC Plus model?
Sure. They're going to have a number of different learning events, different webinars. They're actually going to have some locality events where they'll bring folks together in either a virtual or a physical setting to kind of talk about what's working under CPC Plus, what isn't, how can we come together and make these things work better if we need to. But it's going to be a combination of in-person, virtual, and some on-demand events. And if you go out to that innovation website for CPC Plus, they have an area there that has to do with events. And, I think one of the really good things, and keep in mind this is coming from a consultant, is you have to have a provider number to even get into a lot of these events. So consultants really aren't there. And it is just almost a peer-to-peer, this is what we're doing and it's working, or this is what we're doing and it's not working, or, hey, CMS, we want to accomplish this. How do you recommend we go about it? They have that ability to kind of guide folks and set up that kind of learning network and compatibility and comprehensive discussion network to really help everybody try to succeed and find ways that everybody can succeed. So they're certainly not going to have everybody apply and then kind of be out on their own. They're going to apply, or provide, I should say, a lot of different means by which practices can go out and really enhance the way that they're performing under the model.
Great, thank you for that. Looks like we may have time for one more before we wrap it up. It comes from Brenna. She says, we're also in an rural health clinic under a CAH. I tell you, I can't talk today. We bill method 2. So bill to Medicare Part B and are eligible for MIPS and MACRA and previously PQRS. Would we qualify for CPC Plus? I can reread that.
That is a very good question. No, that's a very good question. I don't believe so because of the RHC designation. Now, that being said, I would reach out to Medicare, and let me try to reach out as well. Nikki, if you could pass along her contact information for me, let me do a little bit of research on that as well, and let me see what kind of an answer I can get. Because you do have that with the method 2 billing, to your point, you do have the, MIPS and macro reporting, assuming that you fall above the low volume threshold. So it would make sense that you should be able to then do some practice transformation things, and that shouldn't disqualify you. So let me actually let me look into that a little bit this afternoon, and I'll get back to you just as soon as I can.
Okay, great. Thank you for that. All right, there were a couple others that came in, and as mentioned, we will absolutely forward these directly to Steve for his direct follow-up as well. But as we are wrapping up, I did want to take a quick moment to invite you on behalf of Region 8 to a live opportunity to hear topics similar to the one discussed today, as well as network with your peers by attending the Mid-America Summer Institute on August 7th through the 9th at Kansas City Convention Center. If you'd like to learn more, please visit their website at hfmaregion8.org. So thank you again to our guest speaker, Steve Smith of BKD CPAs and Advisors, for imparting such great information with our members and our followers today. So thank you, Steve, for joining us. And
thank you very much.
Absolutely, glad to have you. And again, on behalf of HFMA Region 8, we'd like to thank you again for joining, and have a great afternoon, everyone.